Good afternoon, everyone, and welcome to the Lynn Cancer Institute updates for 2025. This is important information for everyone from our physician panel series. We're very grateful to have you all with us today to learn about head and neck cancer from our amazing speakers, Dr. Michael Glahn, the medical director of the Head and Neck Surgical Oncology, Dr. Ross Taylor, radiation oncology, Dr. Mathin Matthew, medical oncology, and Brandy Hyatt, our senior oncology clinical dietitian. At the Lynn Cancer Institute, we believe that education and awareness, prevention, screening and early detection, a variety of treatment options, our latest technology, and the expertise of our staff. And as we're seeing today, the benefit of our multimodality method of treatment, all combined, will truly save lives. In the interest of time, each of our speakers' bios were sent to you by email. During their presentation, we invite you to please take notes. And if you have any questions or comments, please put them in either the chat box or the Q&A box. And there will be time at the end of the presentation for the individual speaker to address your question. And now we're very proud to welcome you to the Lynn Cancer Institute and introduce our first speaker, Dr. Michael Glahn.
Thank you so much for that introduction, and thanks for organizing this great talk. It's been wonderful joining the Lynn Cancer Institute and have some wonderful panelists here. So I just want to, first of all, thank everyone who put this together, and also just thank any of my patients who are on the call for giving us such meaning to our work and for fighting against the cancers that you have, and we're part of this team, and it's a great honor. So we'll go into that a little more in depth, but each one of us is going to talk a little bit about an overview of what happens for the head and neck cancer population. Just talk about what type of cancers we're working on together as a team, and talk about the different ways and improvements that we've had. So there's been leaps and bounds in terms of the improvements in head and neck cancer care, and it's a wonderful thing to be able to bring that to the Boca community in this community setting, but giving state-of-the-art, top-of-the-line care in every single realm. So without further ado, when we talk about head and neck cancer, we have a number of subsites, and so it does span across quite a large spectrum, even though we say, oh, what's the head and neck? So just to clarify and make sure everyone's aware, and I know some of you on this talk, may have one of these and you're battling with this. So we talk about sinonasal, so just kind of part of the sinuses, the nose. We talk about the oral cavity, and the oral cavity is really going to be the very front, not including the back of your tongue, but the very front. So the tongue itself, the buccal mucosa, the mucosa around the teeth, the floor of mouth, the lips, going to the oropharynx, and oropharyngeal carcinoma, squamous cell carcinoma is becoming more and more prevalent. The oropharynx is including the tonsils, the back of the palate, and the base of tongue. So downwards, you have the larynx, and that includes the area above the vocal cords themselves, and then immediately beneath the vocal cords. That's all classified as laryngeal. And then we have salivary glands. So that's your parotid, which are the glands in your face, and also the submandibular glands. And these are the glands that create saliva, and unfortunately sometimes can be problematic as well. The thyroid, which is main metabolism gland in our neck. And then also sometimes very rare, but involvement of the ear, mainly for skin cancers. And then very often folks will present with just an isolated neck mass. And so trying to figure out what's going on in terms of lymph nodes that might arise in the neck, and being able to work that up in a timely fashion so that if we're dealing with a lymphoma, we know that we can get started very quickly, or if we're dealing with a base of tongue tumor that somehow went to a lymph node in the neck, we can just as well deal with that very quickly. This is critical, and it's just an absolute joy to work at Lynn, where we really have every single one of these portions and every single one of these players working together. Head and neck is a subsite of cancer that can be disfiguring physically, just to the eye, but it can also take away a number of functions. It can affect swallow, it can affect speech, and these things are so critical to how we connect to one another as human beings, that having a really well-oiled team and having so many folks that are able to help you with therapy is critical, because if they can give you their level of expertise, that's great. But if they don't have the therapist to then help you get through whatever impediments you've been given from their therapy, then you can't do as well as you may have. I'm helping with the surgical oncology portion, and a number of my colleagues help with that as well. We'll talk a little bit more about that. Dr. Matthew's going to talk about the medical oncology, and Dr. Taylor today about the radiation oncology. We also have a wonderful endocrinologist part of the Baptist system. Our radiology team has been spectacular at getting our imaging done in a very timely fashion, and we have a number of subsites throughout the city and across to different cities that help to make sure we get CT scans, MRIs, PET scans, all done in a timely fashion. Some of the imaging we need within head and neck is very specific and requires a lot of expertise, and there's been no problem in getting all of that going here. Pathology has been top of the line. We have initiated some wonderful new genetic testing with much of our pathology, and also some tumor markers. And it's just been wonderful to work with the pathology team with an open dialogue and get things going since I started my practice here in September, to make sure that any changes that arise within the head and neck community, we're able to adopt immediately with the pathology department. So that's been great. Palliative care and psychology. So not all institutions are able to provide amazing pain and palliative support through cancer care, and that can really be difficult when you don't have that. And I have worked at institutions that can't provide that, and that here at Lynn, we have an excellent palliative care group who's been helping some of my patients get through care with as little pain as possible, and with great emotional support, and really just giving them the time they need to speak their mind, talk about their symptoms, and see how much we can do to alleviate those symptoms. And that's just been critical. Interventional radiology, part of our head and neck care team, helping to expedite G-tubes. Sometimes if the cancer care is too difficult at a certain point, we might need to do a G-tube to avoid inflammation of the oral cavity, and to allow for nutrition that is going to circumvent any swallowing problems. And that's been wonderful to have our interventional radiology colleagues from that perspective, but also working with us as a team when there are certain biopsies that might need to be done. Say, you see something in the lung or what may be, and see if we can get biopsies done. And they've been critical in helping us. So again, a huge team here. Brandy's going to speak with us later about nutrition, and nutrition through our head and neck cancer care is just critical. A lot of weight loss can happen when you're trying to, say, radiate a tonsil cancer. And so optimizing nutrition and getting our bodies, our patients' bodies as strong as possible as we go forward into this marathon of cancer care is critical. And having actual nutritionists who are focused on oncology is just top of the line. I've alluded to this, but our speech and swallow therapists are a huge asset and critical, again, for head and neck cancer care, because if we cure cancer, but we leave you with a persistent inability to swallow, and no way of working through that, and no way of trying to at least rehabilitate some portion of that, then we haven't done our full job. So having the ability to say, okay, before you go into treatment, we're going to do a swallow study and see how you're doing. And when you finish with treatment, we're going to do a swallow study and get you through with some therapy. Giving forward that therapy for speech and swallow is critical. Again, speaking and eating, I mean, it's critical to how we connect with one another as human beings. So I really am blessed to be able to work with this team of therapists and have that support. PT, the physical therapist, as it pertains to my portion of things, we do a lot of surgeries that can affect the shoulder. And having them, they've been seeing every single patient that stays overnight and has had a neck dissection, has had the wonderful ability to see the occupational therapist and get started on a shoulder therapy regimen. And if they have any difficulty with it, then they're able to do outpatient therapy. And have had some wonderful help from our physical therapists with state of the art equipment at their beautiful gym, which I'd like to become a member of, and just giving some great care to the patients who need it. Lymphedema, you can never tell who's going to have bad lymphedema. And what that means is when you remove lymph nodes, you kind of have a blockage. And the blockage there can cause severe swelling and can cause, not only physical deformity, but it can also be very uncomfortable. Sometimes that backup can also cause some swallowing problems and some breathing problems. So having dedicated lymphedema therapists is a huge plus to the head and neck cancer team, and continuing to bolster that group is going to be wonderful as we continue to grow in the head and neck cancer realm here at Lynn. And then goes without saying, but worth much appreciation is our social services and nurse navigation. So since I've started here, we have had the initiation of our head and neck cancer tumor board, which is done most weeks. And this weekly meeting enables us to come together as a team, not just the physicians, but also our nutrition team and our social workers, to make sure that we're able to help folks, navigate any social issues. So do they need help with getting to the appointments, coordinating rides? Is their insurance giving this, that, and the other in terms of some barriers, and try to address that. And that also goes back to the psychology of things and making sure they feel supported through everything they're going through. And then a special thing is having nurse navigation, and they've been able to join us and guide us as we put forward tumor board. Especially want to give a huge thank you to Colleen Rogers, who's been pushing things forward in such a wonderful way as our main nurse navigator. Talking about prevention, that is the most critical thing. And I think a lot of my patients come in with or without cancer asking about prevention. So I want to take a moment to talk about that for the community members here. To prevent head and neck cancer, the things we can always do, and this goes without saying, is if you are smoking, get on a pathway to quit smoking. Call my office. We'd love to talk to you about it. But either go to a class, if you need to start a patch, if you need to start a therapeutic, that's huge. And if you can come here and throw your cigarettes away, we'll take a picture of the trash can for you. Okay. So smoking is huge contributor to head and neck cancer care. Reducing your alcohol intake is also helpful. Regular dental visits. We have so many folks who are coming in, and actually their dentist is the one finding their tongue cancer and such. So continuing on with regular dental visits, these are the people who are looking in the mouth the most. So that's huge. A balanced diet, especially reducing acid reflux. And if you have acid reflux, working with your primary care doctor to reduce that, whether it be through medication or through dietary change. And then the last thing, and this is critical, and Dr. Matthews is going to talk a little bit about this vaccine in a different sense, but the HPV vaccination. So Gardasil is either a 2 or a 3 dose vaccination, and it is basically the only vaccination that can say that it prevents cancer. Oropharyngeal cancer that is HPV positive or spread from the human papillomavirus is continuing to be very, very prevalent, especially in our community. And if you are 45 or under, even if you are monogamous, you are recommended to have that vaccination to prevent cancer. It prevents tonsil cancer, prevents base of tongue cancer, and I'm hopeful that in the span of my career, I'm hopeful that I see less tonsil cancer and less base of tongue cancer because of this vaccine. We are already seeing a huge reduction in cervical cancer because of the HPV vaccination, but we need to get more men, particularly young boys, to get the vaccination to avoid future. So these are the things we can do for prevention. Talking a little bit about my realm, and other than kind of the coordination of these teams, is surgical oncology. So what is most important to me is to make sure that we can provide our patients with state-of-the-art care. And nowadays that includes a lot of tech. Okay, so in my office, we have high definition, flexible nasal laryngoscopy, or the nasal scope that people are familiar with, and make sure that we are able to take photos, high definition photos, see the tumors appropriately, know what we can do for workup. Our office also is able to provide stroboscopy to evaluate the voice, and then work together with our speech pathologists to ensure that we can improve voice outcomes if there are any issues. Also, just getting biopsies done in a quick and timely fashion. I have so many folks that'll come through really stressed because they know that they've got something, but no one will take a piece of it. And how long is it going to take you to take a piece of it? And I really try to, if it's possible, that the moment you step into the office, we can get everything done for you. That's what I try to do. So we have channeled scopes where you can use the camera and have a little forcep come through to do the biopsy. We also are using an ultrasound to do fine needle aspirations and core biopsies. And then we also have the ability to do nasal endoscopy. And if there's anything in the nose, do some biopsies that way. So really just don't want to delay anything as it comes to cancer care. I think where you go first matters, and where you go first should not delay things. So once you're here, we want to make sure that everything is done in a quick fashion. Once we're talking surgery, again, the dysfunction is paramount. So the first thing is curing the cancer as it comes to surgery. But the second thing is making sure that what you do is not so destructive that you've disabled the person to lead a normal life. So as much as we can minimize functional and cosmetic impairments, that's what we're doing. And that sometimes means a dual surgeon approach, that you're working with more than one surgeon, but whatever we can do. The second thing would be, if we know you're going to have to get radiation as a patient, then making sure your surgery will provide you with the support to bolster you through that. Minimally invasive surgery is very helpful, and utilize as much as we can. When we're talking about the vocal cords, they're so tiny, and any little mistake you might make could lead to a change in voice. So sometimes the laser can be very helpful for laryngeal microsurgery. Endoscopic skull-based surgeries, when we're using cameras in the nose to make sure we're removing cancers, but not making any functional deficits of the face, no scars on the face. So that's been a really wonderful advance within head and neck surgery. And then the transoral robotic surgery program, we're hoping to get off the ground sometime this year. So stay tuned as it comes to that. But that is critical, especially when we talk about the HPV tonsil invasive tongue cancers. And then coordinating with our local dermatologist to make sure that we can provide reconstruction for Mohs surgery has been very helpful for our patients as well. Some of the high tech that we have within the operating room includes monitoring, so nerve monitoring. This has been going on for a long time, but it suffices to say, just mentioning it here. So if we're doing surgery on the face and getting near the facial nerve, we're able to monitor the facial nerve throughout the case. If we're doing surgery on the thyroid, we're able to monitor the recurrent laryngeal nerve, or the nerve that gives you your voice, throughout the case. And then in the next few weeks, we'll be rolling out technology for the parathyroid, and that's the small glands around the thyroid that help regulate your calcium. We'll be bringing that forward as a means of monitoring for only appropriate cases, but it's a great intervention as well. So without further ado, I will hand the baton over to a wonderful colleague here, Dr. Ross Taylor, to talk about all the advances we have in radiation oncology. And it's been wonderful to work together with him. I'll be back at the end again.
Thank you, Dr. Glahn. And thank you everyone for having me this afternoon. I think that the sentiment has been made by Dr. Glahn, how incredibly important it is to have a multidisciplinary team when we're talking about head and neck malignancies. It's one of the many sites that we deal with, but it's an extremely challenging site due to the anatomy, right? There's a lot of important real estate in the head and neck. And so the challenge has been, how do we get cure rates for these malignancies, but minimize the symptoms? And so radiation has come a long way in the last 20 to 30 years, and I'm hoping to highlight some of those things and some of the incredible technology we have here at Lynn to facilitate that. So really quickly want to just briefly discuss and talk about what is radiation, what is therapeutic radiation. And so you see here, maybe you recognize it from grade school, the electromagnetic spectrum. And so radiation is just energy that travels and spreads out as it moves. And so you can see as we have larger wavelengths like radio waves, microwaves, but as we get further to the right, you can see that we're increasing energy by shortening the wavelength. And so what we care about in radiation oncology is ionizing radiation and those effects and those biologic effects, right? These anti-cancer effects. And so what you're seeing on the right here is just a diagram of those biologic effects on DNA. So what happens is you have this high energy photon that interacts with matter, in this case, the tumor itself. It can either have direct action or indirect. And so that direct action is a photon interacts with an electron, and that electron is then destabilizing or breaking the DNA. The indirect action is where an electron interacts with a water molecule, and then the water molecule becomes what we call a free radical, and again, interacts with the DNA, breaking the DNA. Once the DNA is broken, tumor cells do not have the ability to repair themselves, and the cell dies. Next slide, please, Dr. Klon. When we talk about how we use radiation in head and neck cancers, it's quite diverse. We use it as definitive treatment, and that usually means as a curative intent. And that's oftentimes concurrent with some sort of systemic agent, chemotherapy, immunotherapies, and so on. So oral pharyngeal, nasopharynx, laryngeal cancers, all of those are great examples of how we use radiation in a curative sense. When we talk about adjuvant treatment, adjuvant sort of meaning complementary, oftentimes after Dr. Glahn has performed a surgery, there are things that we need to address. And those sort of higher risk factors, depending on the location, the pathology, the histology, all of these sort of come into play when we talk about giving radiation postoperatively. Some examples of that, as you can see here: oral cavity malignancies, salivary gland malignancies, and so on. And then radiation can be used outside of sort of a curative or complementary sense. We treat oftentimes in the palliative setting. So what that means is using radiation to relieve symptoms. And radiation can be quite good at that when we talk about metastatic disease, lesions in the bone, for instance. And so we sort of have a role across the board in multiple subsites in the head and neck world. Next slide, please. So when we talk about the advances of radiation, I think it's really important to understand that, the goal here is to increase the therapeutic ratio, i.e., how do we get as much radiation to the tumor itself, but at the same time spare the normal healthy tissue. And so this has been an ongoing challenge. And I think that over the course of the next few minutes, you'll hopefully understand the advances that we've made in the world of radiation oncology. So what you're seeing here on the left that says 2D, this is, up until probably the early 2000s, this was how we were, treating patients. You can see an X-ray. You can see somebody has actually drawn an image on that X-ray, which represents what we call a block, where they would make a lead block that would block out the normal tissue. and we would just send a big field of radiation. As you can imagine, that caused quite a lot of side effects. The next iteration you can see here is what we call 3D radiation or 3D conformal radiation, where we have a little more control over what we're treating and how we're treating. The representation of the red, sort of in the middle of that square, is representing the high dose region of radiation. As you can see, there's a lot of that normal tissue that's receiving high dose radiation. Again, sort of not an ideal situation. If we go to the next slide, please, Dr. Klon. Now we're talking about where we are currently in the world of radiation. We have things called intensity modulated radiation therapy, volumetric modulated arc therapy. These are all very advanced techniques, again, to get the high dose of radiation to kill the tumor cells and relieve you from symptoms to the normal tissues. What you can see on the slide on the left side is that 3D conformal image I showed previously. But if you look on the other side, you see that area of red. That's that high dose region where the tumor is sitting. As you see sort of further on the outskirts, that blue color, that's a low dose area where oftentimes you can have some symptoms, but they tend to be significantly less than what you would receive from that area within the red volume. We're very fortunate here at Lynn that we have multiple modalities. Something that's relatively new in regards to radiation is the ability to adapt a radiation plan on the fly. Usually when we give radiation, we make a plan, and every single day you receive that same plan. We have a machine here, we're very fortunate to have, where we have the ability to adapt the plan based on the daily anatomy. So what you can see here on the first sort of image, that's the plan that was made at the onset of treatment. On the far side, you can see what the plan would look like on the daily anatomy. What you're seeing there is actually some of the radiation dose going into the spinal cord. You can see on the right side, it's actually the dose is going into that left parotid gland. And so that's not ideal. So that middle is what the adaptive plan looks like, where you're getting the dose out of the spinal cord, getting the dose off of the parotid gland, and then you're getting those high dose regions to be even hotter. So this is an incredible technology to have, and we use it for head and neck cancers. We use it for all kinds of cancers. So we're very fortunate to have this type of technology here at Lynn. And then lastly, many of you may have heard of proton therapy. If you don't mind going to the next slide, Dr. Cullen, thank you. We oftentimes hear about proton therapy when we're meeting with patients. And in the role and in the context of head and neck cancers, it's certainly something that we're excited about. Protons have a very unique property in that they are able to deposit their energy or radiation, but the exit dose is almost zero. So on the graph here, if you pay attention to that sort of orange-red line, that's your typical X-ray or photon radiation. If we're looking at the graph as if it's going through the skin to the site of the tumor, you can see that all that energy sort of linearly decays over time. But as we get past the tumor, you can see there's still a lot of dose that's in that deep tissue. In the blue, you're seeing what we call a proton. If you look at the solid blue line, you see that as you go forward, there's low energy, it sort of escalates and deposits its energy and then has a really steep dose fall off. So all of that deep tissue, all of that exit dose is gone. And what does that mean? So that means that we can spare all of that really important anatomy, all that really important real estate that isn't affected by the cancer. So a representation of that is on the other side here. So you can see on the right side, this is your typical photon plan, right? Your X-ray plan, where you can see the high dose region, but then you can see all that low dose exit dose covering the entire head and neck region. When we look at the proton therapy, you can see that we've got the high dose region attacking the cancer, but then we have a steep dose fall off, sparing the majority of the head and neck region. And so this technology can be really valuable in multiple sites in the head and neck region. So we're really excited about this. This is, something that has been long in the works. And actually, yesterday was a really important day. The actual machine was getting dropped into the building. So we're proud to introduce that we're going to be having a proton center here at Lynn Cancer Institute, opening early 2026. And it really is just going to give us that extra thing in the toolbox in regards to how we treat our patients. And so, again, we're really fortunate here that we have extremely incredible technologies to help treat patients. And this is just one extra thing in our toolbox to help with that. Thank you, everyone.
All right. Thank you, Dr. Taylor. So good afternoon, everybody. I'm Dr. Mothan Matthew. I'm one of the medical oncologists here at the Lynn Cancer Institute. And I'm going to talk to you today a little bit about the medical oncology updates, particularly about systemic therapy, which I mean treatment through the body. And so starting here with what's standard in 2024, as well as where we're going with immunotherapy and some of the novel vaccine studies, and then what's coming up next. So Dr. Galan, can you advance the slide for me? Thank you. So to start, this slide summarizes the current systemic treatment approaches in head and neck cancer in 2025, both the curative as well as palliative strategies that we're using. And Dr. Taylor talked about this a little bit. So we have in curative intent approaches, induction chemotherapy, which involves giving cisplatin-based chemotherapy up front. This is typically followed by either radiation alone or concurrent chemoradiation, or even surgery sometimes, depending on patient-specific factors such as disease burden, location, and performance status. Definitive chemoradiotherapy remains a cornerstone for many patients, particularly those with locally advanced disease not amenable to surgery. And this approach combines cisplatin-based chemotherapy in conjunction with radiation. And adjuvant chemoradiation is used postoperatively for patients with high-risk pathologic features, and this sequence involves surgery first, followed by cisplatin chemotherapy along with radiation. Now, it is important to note, and I'm the first to admit, that systemic therapy with chemotherapy alone cannot cure head and neck cancers. I think the only two approaches that can do that are surgery, with Dr. Glaun mentioned, and radiation that Dr. Taylor mentioned. But chemotherapy can certainly help potentiate some of these, particularly with radiation. But in the transitioning to the palliative approach, systemic therapy really is the standard of care. And this is in patients with recurrent or metastatic disease not suitable for curative intent treatment. Systemic therapy with immunotherapy or alone or in combination with chemotherapy, largely driven by PD-L1 expression, and high PD-L1 scores or immune scores may allow for immunotherapy on its own, whereas lower scores we usually necessitate combination approaches. And as I said, it's important to note that cisplatin remains the backbone of chemotherapy, though alternative regimens may be considered. Next slide, please. I think immunotherapy is a really powerful tool that we've learned much more about. This is a simplified way to show how immunotherapy works. And it's really changed how we treat a lot of cancers, including head and neck cancer. Normally, your immune system has special cells called T cells here in the blue that can recognize and attack things that don't belong there, like cancer cells. But cancer cells are sneaky, and they come up with ways to evade the immune system or put up stop signs that tell the T cells not to attack. This image shows two of these most important signals, one of which is called PD-1 or PD-L1, and it acts as kind of a handshake between the cancer cells and the immune cell that says, leave me alone. The other, CTLA-4, is another brake that slows down the immune system. The exciting breakthrough in cancer treatment have been drugs like immunotherapy that block these brakes, and drugs like pembrolizumab or Keytruda or nivolumab or Opdivo block the PD-1 handshake, helping the immune system to see these and attack cancer. Another drug called ipilimumab or Yervoy blocks the CTLA-4 brake, helping immune cells stay more active. The development of these drugs has led to a Nobel Prize, and removing these brakes, we're really helping the immune system to do what it's naturally good at, which is finding and eliminating cancer. Next slide, please. So this is how far we've come in the world of immunotherapy for head and neck cancer over the past decade. It really all started in 2013, 2014, when clinical trials first began taking these drugs like Keytruda and Opdivo, both of which help the immune system and attack cancer. Fast forward to 2016, and we had approvals for these drugs in patients with advanced recurrent head and neck cancers who had already tried other treatments. And then in 2018, another drug, cemiplimab, was approved for certain types of skin cancers. By 2019, the field really exploded, and immunotherapy wasn't just for second-line treatment, but pembrolizumab was approved as the first-line option for patients with advanced head and neck cancer, and sometimes by itself or in combination with chemo. Now, in 2025 and beyond, we're really in a phase of continued innovation, and new trials are exploring how we might move immunotherapy even earlier, before surgery, during radiation, or even after surgery, all with the hope of improving outcomes while minimizing side effects. An exciting area of research in head and neck cancer involves the therapeutic vaccines targeting HPV-related cancers. And many people are familiar with the HPV vaccine that Dr. Glaun was referring to prevent HPV infection, especially to prevent cervical cancer. But this is something different. These are therapeutic vaccines designed not only to prevent cancer, but also to help it treat it once it's already developed, by training the immune system to better recognize and attack cancer cells driven by the HPV virus. Here's how it works. So HPV-related cancers often carry a viral protein called E6 or E7 that don't exist in normal cells. These vaccines teach the immune system to look for these specific viral proteins and act like a wanted poster on the cancer cells so that your immune system can find and deactivate them. There are a few different vaccines under development. One of them, ISA 101B, is a long peptide vaccine that gives small fragments of the HPV protein to trigger an immune response. HB200 is a RNA-based vaccine that uses a arenavirus or viral delivery system to teach the immune system to target HPV proteins. And Q101 is a fusion protein that delivers HPV targets directly to the immune cells, along with an immune boosting signal called an adjuvant. All of these are still in clinical trials, but early results are promising, and the hope is that these vaccines, alongside other treatments like immunotherapy and chemotherapy, could help patients with HPV-related cancers have better responses and longer-lasting disease control. So this is a schema of a recent early phase clinical trial that evaluated the HB200 vaccine in conjunction with pembrolizumab in advanced HPV-positive head and neck cancer. So this is for patients whose cancer was related to HPV and had come back or spread, and who hadn't had prior treatment for advanced or metastatic disease. And in this study, the patients received HB200 through IV every 3 weeks, along with Keytruda, which is a standard immunotherapy drug. And the treatment continued until the cancer grew or the side effects became severe. And the researchers were measuring the response rate, or did the tumor shrink or did it grow, their survival, how long do the patients live, and disease control, and did the disease cancer stay stable for a while, as well as the immune response, which was how did the patients develop more T-cell fighting immune cells. So here's some results from the trial, which are, as I said, are encouraging. On the left, you can see the number of 35 patients with advanced head and neck cancer that was HPV related. And out of these, about 37% of patients had their tumors shrink significantly. That's the overall response rate, or ORR. About 11% actually had their tumors disappear completely. That's a complete response. And when you add in the patients whose tumor stayed stable without growing, that's almost 69% of patients had some meaningful disease control. And that's a pretty good result for patients with advanced cancer, particularly for an early phase clinical trial. On the right, the chart shows what happened to each patient individually. And each bar represents a single patient, with bars going down, meaning the tumor got smaller, and bars going up, meaning the tumor got bigger. You can see a lot of the bars here are going down, meaning that patients saw shrinkage of their tumors, and some dramatically so. The colors show a little bit more detail. The red bars are patients with lower levels of PD-L1, and blue bars are patients with higher levels of PD-L1. Again, that's that immune protein that we use. What's promising is that the responses were seen across both groups, suggesting this vaccine may help a broad range of patients, not just those with very high PD-L1 levels. And the big picture takeaway is that these early results are exciting and showing that combining this vaccine with immunotherapy could help patients with difficult to treat HPV-related cancers. This is, of course, early research, and there are larger trials ongoing to confirm these results, but it's another hopeful step. And this is actually a phase 3 trial that we're looking to potentially open here at Lynn using this particular vaccine. So looking ahead, I lastly just wanted to highlight an exciting study that could change the future treatment of head and neck cancer that should be available later this year. This is a large clinical trial called the Keynote 689 study. It's looking at whether adding immunotherapy before and after surgery might improve outcomes for patients with certain head and neck cancers. Traditionally, treatment for head and neck cancer involves surgery to remove the tumor, followed by radiation and chemotherapy, depending on risk factors. But this study tests a new idea. giving a couple doses of pembrolizumab or Keytruda, an immunotherapy drug, before surgery to help wake up the immune system and start fighting cancer early. Then after surgery, when patients continue their usual treatments like radiation, sometimes combined with more immunotherapy. So this is important because immunotherapy might be right before surgery, help shrink the tumor, and also help the immune system recognize that any leftover cancer cells can be dealt with down the line. It also reduces the chance of the cancer coming back. So this trial is still ongoing, but early results are expected this year. And just to highlight some of this top line data, next slide, please. The results from the top line stuff, which means just that the take home points, were announced last fall, and the FDA has actually given priority review to this new approach. That means that the data from the trial was promising enough and that the FDA is fast tracking its review, and it could lead to a new treatment strategy being officially approved as early as mid 2025. What does this mean for patients? I think if it's approved, this would be a first-time immunotherapy like pembrolizumab could become part of routine treatment before and after surgery for patients with head and neck cancer that can still be removed with surgery. It's a huge shift from where we are and where we were just a few years ago when immunotherapy was only for patients for advanced disease. In simpler terms, what it means is this could help patients live longer with better outcomes by getting the immune system involved early, not just relying on surgery or radiation alone. And it's an exciting sign of progress and one that I hope will quickly lead to real-world benefits for patients this year. So to wrap up, here's a big picture of where we are and where we're headed in terms of treating head and neck cancer. First, chemotherapy combined with radiation is still the standard approach, particularly for patients with aggressive curative intent treatment that hasn't changed. That cisplatin particularly is the chemotherapy of choice. However, patients with advanced or metastatic disease where cure might not be possible, immunotherapy, sometimes with chemotherapy, has become a game changer, and it's helping patients live longer and better with fewer side effects compared to chemotherapy on its own. Looking ahead, I think one of the most exciting areas is the development of therapeutic vaccines such as HPV-related tumor vaccines, and these are still in early testing but offer a new strategy. And finally, future treatments looking at immunotherapy even earlier in the treatment process, before and after surgery, with the hope of shrinking tumors and boosting the immune response, are very exciting. In short, I think the future of head and neck cancer is becoming smarter, more targeted, and more personalized, with a growing role for the immune system at every step. So with that, I'll hand it over to Brandy, and we'll be around later for questions.
Hi, good afternoon, everybody. My name is Brandy, and I'm one of the senior clinical oncology dietitians here at the Lynn Cancer Institute. Excited to be here today to discuss the nutrition challenges that our head and neck cancer population faces, as well as what the role is for the Lynn Cancer Institute's nutrition team. So our role as a nutrition team is to really help to disseminate the information about the importance of nutrition and to also be a resource for our patients so that we can maximize their nutrition related questions and concerns. We're also here to assist in managing potential side effects that could occur from any of the different treatment modalities and focus on the cans of eating. In a world where we are faced with so many things that we should not or cannot eat, it's really important to focus in order to maximize nutritional status on what we can eat. And we also work closely with our support team. Next slide. So why is nutrition important? So 75 to 80% of the patients that we see with a diagnosis of head and neck cancer will have significant weight loss, either coming into the treatment or throughout the treatment. And 35 to 60% of our patients will be diagnosed with malnutrition at the time of diagnosis. Now, malnutrition occurs when the body doesn't get the right balance of nutrients to make it properly function. So nutrition is here to help our patients maintain their strength and their weight and build that healthy foundation that we know that they need to help them maximize their successful journey through their treatment. Nutrition is important to help manage side effects as well as recovery and healing. So when we talk about side effects, I've listed out some of our major side effects that we as a nutrition team deal with mostly. And when we have a population that we know is going to experience, when 75 to 80% of our population experiences significant weight loss, we know that there's some alterations in how and what they can eat. So as the team, we like to pull out our toolbox and make sure that we can help them navigate what they are eating with some of the tools. A lot of times our patients will experience taste changes. So because of the chemos, because of the radiation, the metal taste or the acidic taste is really high a possibility. So with the taste changes, if a patient does have the metal taste, there are some rinses that they can use to take the metal out. For the acidic and the sour taste, we have this really cool berry. It's actually called miracle fruit, which contains the glycoprotein miraculin, which binds to the taste buds on the tongue that actually enhance the sweet taste buds. So if a patient were to eat something acidic or sour, then it's like if you were to take a bite of a lemon and you had the miracle fruit in your mouth, it would taste like lemonade. So we can alter some of the taste profiles in some of our foods. Loss of appetite is a huge complaint as well, or a huge side effect. What physiologically is happening, the tumors are sending a message to the brain and telling the brain that the body is not hungry. But we know that the body needs the nourishment, the calories, the protein, so that it enhances their journey. So we help our patients navigate that just not wanting to eat, that loss of appetite, which could potentially lead to the significant weight loss that we may see sometimes. Modifying texture of food is something that we do to help with alleviating some of the issues with maybe some pain or the scratchy throat that may accumulate from some of the radiation. Also, the dry mouth is very common, and there are different rinses and sprays and gels. There's a really cool product out there too called Flint Mints, which is a natural herb that stimulates the salivary gland to produce more saliva and just make that less of an issue. Mucositis is also a side effect that we help manage as well. So mucositis is when a patient experiences more of like a phlegmy kind of mucus that comes up during the treatment. And so we recommend a product called Helios, which is basically a broken up protein called glucosamine that will help heal the oral mucosa. And then lastly, we are part of the team and we help manage feeding tubes. We make sure that the patients have the supplies that they need and the recommendation as far as what needs to go into the feeding tube. And we do help with that because although a feeding tube can be a little bit intimidating in the beginning of a treatment, we know as the practitioners that it is something that could be very useful and very important, especially as a patient continues in their treatment. Next slide, please. So focusing on the cans, every day I hear a patient tell me, well, I can't eat this, or sugar feeds cancer, or I can't eat soy. So there's always this information that is either online or disseminated through friends or family. So we as a nutrition team want to talk about how you're going to maximize those foods that you can eat. So we break down your journey into 3 sections. So we talk about before, during, and after treatment. And before treatment, our focus is really to help you build your nutritional reserves. You may be one of the patients that come in and you're already malnourished. Well, now it's time that we really focus on how we're going to maximize those calories and protein to build you up a little bit before treatment starts. And we also focus not only on the nutritional reserves, but also on hydration as well. Next slide. During treatment, so again, those side effects usually kick in around the 3rd week of treatment. And again, our goal is to help you maximize your nutrition. So we divide up, or we recommend that you're eating every 2 hours, small amounts with just jam-packed calories and protein. Soft and moist foods really are key in helping us get the maximum amount of nutrition in. And then lastly, when we talk about post-treatment, so just because our treatments are over doesn't mean the nutrition spectrum stops. So it's really important for healing and for recovery that you continue to eat and gradually increase maybe the textures, going from soft pureed to more of a regular texture over time, but really focusing on the nutrients that you are fueling your body with so that you can maximize healing and recovery. And then I always like to throw exercise in there as well. Sometimes it's not something that we think about before or during treatment, although it is very beneficial. But after treatment, it's something that I highly encourage all of my patients to eventually get back on board with because the research is very compelling about the benefits of exercise. So incorporating that 150 minutes per week of moderate intensity and the 2 days per week of resistance training is very key in recovery and healing as well. And then the role of the registered dietitian in the team. So I'm very happy to say that all three of the dietitians here at Lynn Cancer are certified specialists in oncology. And so what that means is that we have all of the tools that we need, and we have studied extensively to receive that certification specifically for our oncology population. So we can help you before, during, and after treatment to help make sure that you're maximizing not only your nutritional status, but also your treatment outcomes as well. We work with the speech language pathologist, as Dr. Galan mentioned previously. So they are super key in the whole journey as well, as far as helping with swallowing therapy and voice restoration. And they too work with physical therapists and help with the edema or the lymphedema. And then lastly, we work with our social workers or our support service team at Lynn Cancer, which include licensed clinical social workers that provide emotional support, group support groups, and resources to patients and family members. And then lastly, I always like to add this last slide, which basically talks about a national support group. Oh, I guess I didn't include it, but we don't have a specific support
We got
group.
it at the end, I think, but carry on.
Okay,
Go
okay.
on.
We don't have a specific support group for our head and neck patients here at Lynn, but there is a nationwide support group that I always like to make sure that the patients know about, because it's one thing to talk to practitioners and then you have your family, but it's also really nice to talk to other patients that are going through the same thing that you're going through. So hopefully that slide will pop up and you'll have that resource. Thank you, everybody, for allowing me to be part of this panel, and I look forward to any questions at the end.
Thank you, Brandy. So coming to a close, one of the advances that we also have is talking about surveillance, and we have now started using NavDX, which is a circulating tumor DNA blood test that we're doing through Naveris, and it allows us to have one blood marker for one of our cancers, which is the HPV positive cancers, and we're able to actually draw that at the time of your surveillance visit. So if you're seeing me every 3 months in the first year after your cancer has been cured, then we'll be drawing this in office every 3 months, and the next year every 4 months, and then thereafter every 6 months. And so far that blood test, which is in the last few years has been developed, has shown to detect recurrences or repeat cancers or when the cancer returns about 4 months earlier than a physical exam or an imaging test. So that's really critical. And then being able to just make sure that you have close follow-up, whether it's with surgical oncology, medical oncology, radiation oncology is really critical. And even the impact of having close follow-up with our nutrition team and our speech and swallow team, who might say, hey, he really is having worse symptoms. We need to look closer and make sure that we're not missing anything. And then again, a great shout out to our imaging team to making sure that we're able to coordinate imaging without any delay. Survivorship support is critical. We're not just about curing the cancer, as I've said a few times here, but we're about ensuring that you have rehabilitation and getting you back to as strong of a you as possible. And so I've listed here a number of things we have. I've mentioned a number of them, but it's really about longitudinal care in this community program. And we have things I haven't mentioned yet is there is some great hyperbaric oxygen for any wounds that carry on, and great wound care support. And then I'm also able to provide voice restoration surgery for those folks who are eligible, and also facial reanimation surgery or Botox when that's indicated. So we've had some great questions come through to the chat. I'm going to try to just read through them. And if you have any more, feel free to put them in the chat. So one of the questions we were asked is about how much of head and neck cancer is associated with the human papillomavirus. So about 25 to 30% of the head and neck cancers in the United States will be associated with this, but as it pertains to the back of the tongue and the tonsils, or base of tongue and tonsils, it's about 60 to 70%. So if we can get folks vaccinated and reduce that amount, then we really will hardly be seeing tonsil and base of tongue cancers. That's very exciting. We also had a question about whether if you're above the age of 45, if you can have the HPV vaccine, if it will help. And it's a wonderful question. Therapeutic vaccines are something that is still in clinical trial. Hopefully we can have more of that available, and we urge you to stay connected to the Lynn Cancer Institute and all the updates. And when that is more available, we'll be in touch. But there are some studies that are currently looking into that very closely, and it's a wonderful thought, again, trying to spark up the immune system. We also had a question about when is it recommended that we start getting dysphagia treatment or a disability in swallowing? When do you start getting treated for that by our speech team? It's a wonderful question. It's very, very important in the head and neck cancer journey. And we hope that we can basically start that before treatment even begins. So right at the get-go, and even just seeing you at your normal so that we can push you along and give you the treatment you need and the therapy you need to try to stay near to normal once you recover from treatment. And then we had some interesting question about Enterade, which is a medical drink. It can be very helpful for folks that are undergoing radiation and chemo, and more information on that. So we are at the top of the hour almost. I just want to take a moment and just say that I feel very humbled to be joining this wonderful team. There are so many people to thank for a wonderful kickstart to the head and neck program. And now that we're a full team, it's just been an honor. So I do want to thank Dr. Morrell and Maureen Mann, and again, Colleen Rogers. Ashley Craig has been very helpful as well. And just want to compliment Doctors Taylor and Matthew and Brandy here today for beautiful talks. And much of our work goes far and beyond these types of seminars and coming together. And all I can say is it's just wonderful to be working with folks who give so much of their heart to what they do, and making sure that we not only cure cancer, but give our heart to our patients and get them through treatment in as strong as a way of possible, so we can continue to increase our family here and stay together and be seeing each other just on social surveillance visits for many years to come. So I wish everyone a beautiful weekend ahead, and all the best as we close this meeting.
Thank you, doctors and Brandy. We all learned so much today, and I think all the audience can agree we're in very good hands. And with all this amazing information, and with the heartfelt sentiments too, that we know, we can feel how much you care for your patients and all of us by educating us for prevention as well as treatment. And we know that we're very fortunate. I think everyone emphasized really the team effort that we have at the Lynn Cancer Institute. And I think that's very comforting for the team as well as the patients and our community. So I want everyone to know that this lecture was recorded. So if you do want to go back and listen to it again, or if you feel like it would be information that would be beneficial for any family or friends, it will be edited and available by next week. And Lee will be sending out an evaluation form. So we appreciate everyone completing the form. At that time, you can request a copy of the link, and she will send that along with her email. And so we want to just give a little update on 2 more lectures that we're going to be having for the month of April. On Wednesday, April 16th, which is National Advanced Directives Day, we will be presenting Plan for Tomorrow today. The Power of Advanced Care Planning, What You Need to Know. This will be presented by our social workers, Elsa Rayner and Ann Williams-Nicholas. On Wednesday, April 23rd, we will be presenting Words from the Heart, The Power of Ethical Wills. This will be presented by Rabbi Marcy Block from Trust Bridge Health. Thank you, doctors. Thank you, Dr. Glahn, for your coordination. We really appreciate each and every one of you for your time that went into all this research and for presenting with us today. And Brandy, you as well. Our nutrition is the basis for our prevention and health and care for our patients. So everyone have a great afternoon and a great weekend. Thank you, everyone. Bye-bye.